The purpose of this video is to discuss the standard approach towards short cases of various clinical presentations in medicine. The individual approach may vary from case to case, but for academic purposes the general approach towards a patient can be split into various subcategories including differential diagnosis, history, risk factors, examination, investigations and treatment. For proper handling of each of given subcategory, the time allocation permitted by exam is the key. It will not only help us to cover all the aspects of a short case but also keep us paced to reach at a conclusive point for passing our exam. For example, if the permitted time is 8 minutes, we can divide the time into phases like 4 minutes for history taking, 2 minutes for examination, and last 3 minutes to discuss management plan. You have been given a case of chest pain. Regarding differential diagnosis, make a quick list of possible causes of a given presenting complaint, and ask questions to rule in, or rule out the possible differentials, as in this case. Myocardial ischemia, pulmonary embolism, pneumonia, musculoskeletal, esophageal reflux, are the top differentials in our list. Here, we are discussing relevant questions to take a brief history, keeping ourselves structured within a given time frame. Ask about pain questions using Socrates PDA, cite, where exactly do you feel the pain most? Usually, crushing central chest pain is of cardiac origin, whereas epigastric pain is due to peptic ulcer disease. Onset, how did the pain start? What were you doing when it started? Determine it is sudden or gradual in onset. Is it the first time, or were there previous episodes? If there were similar episodes in the past, ask, when was the last episode? Character, can you please describe the pain for me? As crushing or squeezing, pressure like chest pain has a cardiac origin, whereas pleuritic type chest pain may be due to pericarditis, respiratory, or musculoskeletal pathology. However, burning like pain is due to gastroesophageal reflux disease, and a band-like shooting pain is due to nerve root involvement. Next, ask about radiation. Does this pain go anywhere else? If the answer is yes, then ask where it goes. Cardiac pain has typical radiation to the left arm, neck, or jaw, and pain radiating to the back may be due to pancreatitis or aortic dissection. Associated symptom. Let's discuss differential diagnosis of chest pain and how to rule them out by asking simple questions. Regarding cardiac pain, ask about sweating, pallor, racing of heart. Have you ever wake up at night breathless? How many pillows do you sleep at night? Have you noticed any swelling in your legs? 4. Pericarditis. Ask about any recent flu-like illness. Next, ask about respiratory chest infection. Ask for any fever, cough, quantity, and color of phlegm. Does it ever contain any blood mixed in it? Furthermore, pulmonary embolism. Ask about any blood in the phlegm, any calf pain or swelling, any recent travel or history of immobilization like any recent surgery. Moreover, malignancy. Ask about any recent weight loss, cough, night sweats, any lumps or bumps. Next, ask about peptic ulcer disease. Have you ever had vomiting containing blood, or any black-colored stool? Whereas, 4. Gastroesophageal reflux disease. Ask, acid taste in your mouth, burning sensation in the chest, difficulty in swallowing, nausea, vomiting. Regarding musculoskeletal pain, ask for any recent trauma. Additionally, 4. Nerve root pain. Ask for any numbness or weakness of limbs and control of bowel or bladder. History of cancer is additional supportive evidence for it. Exacerbating factors. Does anything make it worse? Pain that worsens on exertion reveals cardiac pathology, while pleuritic type chest pain suggests pericarditis, respiratory, or musculoskeletal origin, and Peptic ulcer disease or gastroesophageal reflux disease. Pain exacerbates by eating. Furthermore, pain due to pericarditis, pancreatitis, and gastroesophageal reflux disease worsens by position. Further, ask about relieving factors. Does anything make it better? Cardiac pain improves by rest and the use of nitrates. Ask, have you tried any analgesics? As pain due to pericarditis, respiratory or musculoskeletal origin improves with painkillers. Peptic ulcer disease or gastroesophageal reflux disease pain gets better with the use of antacids. Scale, if I was to give you a scale from 1 to 10, 1 is the lowest and 10 is highest, how do you scale the pain? Progression. Has the pain changed over time? Is it the same, getting better or worse? How is this pain different from previous episodes? Duration. How long is it present? Anything else? At this point, we have ruled out possible differentials and have established the diagnosis of myocardial ischemia. To support it, we can perform a quick physical examination and lab investigations. As in this case, we can check hands for tar-stained fingers and pulse, eyes, xanthelasma, heart and chest for auscultation, peripheries, swollen ankles. Now it's the time to tell the patient about the management part, including investigations and treatment. Regarding investigations, we have options of ECG and chest X-ray, troponin, full blood count, creatinine, fasting lipid profile, glucose. Regarding treatment, we have plan of antithrombotic, antiplatelet, statin and ACE inhibitors, coronary angiography, angioplasty and stent. Meanwhile, address the concerns of the patient. In the end, it's the time to close the case and talk to the examiner.